Welcome to Beauty and the Biz. Discover how to grow your practice with effective cosmetic patient attraction, conversion, and retention advice from author, speaker, trainer, and cosmetic practice business and marketing coach, Catherine Maley, MBA.
Hello and welcome to Beauty and the Biz, where we talk about the business and marketing side of the cosmetic practice. I'm your host, Catherine Maley, author of Your Aesthetic Practice, What Your Patients Are Saying, as well as consultant to cosmetic practices to get them more patients and more profit. And today's episode is really special because my guest, his name is Dr. Mark Constantian, and he is a closed rhinoplasty specialist and plastic reconstructive surgeon in Nashua, New Hampshire. And he's been in practice for more than 40 years. As a matter of fact, he's a native of Massachusetts, and both his father and grandfather practiced medicine. Now, Dr. Constantian teaches regularly at plastic surgery meetings all over the world, and he's past president of the New England Society of Plastic and Reconstructive Surgeons, the Northeastern Society of Plastic Surgeons, and the Rhinoplasty Society. Now, he's also a past member of the board of directors of the American Society of Plastic Surgeons, and he's been an assistant editor of the International Journal Plastic and Reconstructive Surgery. He's assistant clinical professor of surgery, that is plastic surgery, at the University of Wisconsin Medical Center. Now, he offers educational books and videos on his innovative rhinoplasty techniques. And the reason I invited him on as a guest is because I read an article where he was being interviewed because he had authored a book in 2019 called Child Abuse, Body Shame, and Addictive Plastic Surgery, the Face of Trauma. And I thought, wow, that really caught my eye because for all sorts of reasons. So I want to welcome Dr. Constantian on the show, Beauty and the Biz.
Thank you very much for having me.
You are so welcome. And you know what? I just want to open it up with, how did this book come about for you and what possessed you to research it and write about it?
I don't like things that I don't understand. And the usual experience of most plastic surgeons is to have a patient come in with a problem. You operate, patient's happy, they go away happy. Whether it's reconstructive or cosmetic surgery. But I had some patients in the early 90s, I've been in practice maybe a dozen years at the time, whom came almost quickly in succession, and then more that followed it over the next few years, who all had good results, very good results. I could use them as teaching cases in my courses, and yet they were dismally unhappy. One was a university professor who quit her job because she said she looked so bizarre she couldn't appear in public. She only would shop in distant cities. She would only go out at night. And one was another woman who was a physician's wife who became a recluse in her home. And one was a man who tried to cut off his nose with a razor because he was so unhappy with the way things looked. And he didn't do any real damage. But the point was, these were all results that were not only good surgical examples, but they accomplished exactly what the patient told me that he or she wanted. And I couldn't understand this. So I began to go into the mental health literature. And at that time, what I was reading about was a new phenomenon that only was described in the mental health literature in 1987. But now everybody talks about it, which is body dysmorphic disorder or body dysmorphia. And the first criterion of that problem was supposed to be a defect that was so minor only the patient could see it, or it was something imaginary that no one else could see. And yet the patient got very upset, and his or her life was disrupted. And after that, their self-esteem went down, and they had trouble in their families, and some of them developed social anxiety disorder or obsessive-compulsive disorder or depression. They became housebound. The worst ones committed suicide. So there was a lot written about these patients and describing what they looked like, but nobody came up with an explanation for why this happened. And that's what always bothered me. Why do people get like this? And there still is really no explanation. They look for genetic characteristics. They haven't found them. I'm talking about very good mental health researchers. They've looked for neurotransmitter abnormalities in the brain. They haven't found those. They have found a familial occurrence. Anywhere from 5 to 20% of people who have body dysmorphic disorder will also have someone in the family with it. And so this all percolated in my brain as I began to see more patients occasionally like this, because my practice, although it was originally very broadly plastic surgery, because when I came to New Hampshire in the late 70s, there was nobody in the whole southern half of the state except me doing plastic surgery. I wanted to go to an unserved area. And so I did everything. But as time went on, I got more interested in complicated nasal surgery and began writing about it and teaching about it, and people began to associate me with that problem. So the practice got more concentrated in that. And I began to see more of these patients. And that's partly because across all cultures around the world, the nose is the most commonly affected body part, the most commonly obsessed about body part in body dysmorphic disorder. And so it was natural for me to see more of these patients than people who did, say, hand surgery. But I still would see people who ought to have been happy with what I did, who I thought seemed perfectly normal ahead of time, and yet were very unhappy and either hated themselves or hated me afterwards, and I couldn't figure it out. And then I had a man come in to see me once who said, I had body dysmorphic disorder, but I'm all better now. And I thought, So I liked the man very much. I said to him, if you get a note from your therapist that you're stable enough to go through surgery, I'll operate on you. And he did, and I operated on him. Very nice man. We got along well. I still have contact with him. That was 20 years ago. And I said to him afterwards, if I write you a letter with a list of questions about body dysmorphic disorder, will you answer them for me? Because I never met anybody, no surgeons ever meet anybody like you who's all better. They meet people in the disease. He said, sure. So I sent him a bunch of questions. What's it like to feel like it inside it? Do other people recognize what you're going through? Did you meet other people like this? How did the doctors treat you? And so on. And he sent me back a 4-page, single-space letter about his life, which was filled with childhood abuse and neglect. A very turbulent life. An abusive stepfather who, when he was 7 years old, made him submit to photographs so the stepfather could show him in the pictures what was wrong with his nose. Imagine doing that to a child. I've got most of the letter in my book. And by the time he was in high school, he was totally obsessed by this. And then he had surgery, and he got even worse. And he had more surgery on his nose, and he got even worse. And then someone started putting him on medications. And then he ended up on a ventilator, so common now with the virus out there, the ventilator, because he had an idiosyncratic reaction to one of the medications. And he ended up finally in a halfway house for schizophrenics. And then there's this sentence in the letter saying, I suddenly realized that my problem was not my nose. My problem was that I was 30 years old. I never finished school. I never had a job. I didn't have a girlfriend. And I was going to live in places like this forever unless I did something about it. Now, that's a fantastic epiphany. And most patients, it's almost unique, I think, in my experience in BDD patients. Most of them never, very rarely have that epiphany. So I thought, all right, at least in one person, here's an explanation for why people become obsessive about themselves and why they're so filled with shame. And then I began to read more of the mental health literature and more of the childhood development literature and more of the body image literature and the PTSD literature and the body shame literature. And I ended up reading, for this book, there's something like 830 references in it, not because I was trying to turn the tables over in mental health, but because I just wanted to understand this problem. And one of the things I discovered was there were a lot of clues in the literature, but they were scattered. And just like in plastic surgery, people read their own little silo of interest. But I was reading the whole breadth of mental health because anything that seemed relevant, I would read about it in depth. And I began realizing that the people in the body image literature were asking questions that the people in the childhood development literature could answer, but they didn't talk to each other. So I began trying to put this together, and then I wrote 2 papers that came out in 2014 in Plastic and Reconstructive Surgery called Why Some Patients Are Unhappy. And I had looked at 100 consecutive rhinoplasty patients, revision rhinoplasty patients of mine, because I'd noticed one other interesting thing, and that was when I saw new patients, or patients called up and said, I've had nasal surgery and I want another one from the doctor. My staff would say, bring in a photograph of what you looked like before you had surgery, because I thought it would educate me and I'd be able to explain to the patient how the deformities developed. And often these patients would bring noses that look totally normal. No bump, no crookedness, no airway problems. And I'm looking at the picture and I'd say to the patient, what were you trying to accomplish when you had this surgery? Why did you have the surgery? And they say things like, because my mother said I was the ugliest baby she ever saw, or because my sister was much prettier than I was, or because my father said, how come you're not as good an athlete as your brother? Or as one man said to me, I had surgery so people would love me. And I thought, okay, there's something going on here that originally that had nothing to do with the problem. So I wrote about these patients, this group of 100 patients, 50 of whom were like this. They originally had totally normal noses, and 50 of whom originally had deformities. And there were big differences between them. The people who originally had deformities, even if they'd had several operations, were very easy to please. They were very easy on the staff. They weren't demanding or depressed. Very much more pleasant, much more likely to be happy with what I did. The ones who originally had normal noses had more operations, more other cosmetic operations, had started surgery at a younger age, were much more likely to be unhappy with what I did and want another operation, a revision, another revision. And so I began, my point in these papers was there's a difference between people who start off with no problem, if you will, no medical indication for surgery. They're driven by something else, and that's why you can't make them happy. And I thought those papers would set the world on fire, and I don't know if anybody ever read them except me. So, but I kept working on and reading the literature more, and then I came across the Adverse Childhood Experiences study. Are you familiar with that?
I am not, but I sure have studied childhood. Yeah, I'm still trying to get over mine too. Yeah, so I'm very interested in this topic, and I've studied it a lot.
There's a lot. Your listeners can pick it all up on the internet. They can't just go to ACE. They have to go do Adverse Childhood Experiences, because ACE, you'll get high blood pressure medication instead, ACE inhibitors. But if they look for Adverse Childhood Experiences study, it was started in the mid-90s in California at Kaiser Permanente, which you know is a good insurance company. And kind of a long story, but the point was they assayed 17,000 of their patients for 10 common kinds of childhood abuse or neglect. Emotional abuse. You're stupid, you're ugly, you're never going to amount to anything. Emotional neglect, nobody paying any attention to you. Physical abuse, physical neglect where you don't have enough to eat or wear. Sexual abuse, violence against the mother, divorce, alcoholism, mental illness in the family, imprisonment, suicide. I think those are the 10. And they discovered, to their amazement, even though this is not a disadvantaged population, middle class, 80% white, 10% Asian, 10% black, all employed with good health insurance, that 64% of the patients had at least one of those answers. And they were amazed. So was I when I read the study. I thought this can't be true of my patients. I've got, at this point, an elective aesthetic surgery practice. Excuse me?
What's the ratio between male and female?
In that group, they made it 50-50.
Okay.
Yep. And because they have everybody on a computer system, all the health issues are computerized, they discovered two things from this study in 17,000 people. One was that adverse childhood experiences are very common. Second, the more adverse childhood experiences you have, the more health problems you have as an adult. Not just depression and not being able to hold a job, and unwanted pregnancies maybe, or drug abuse, but heart disease, high blood pressure, cancer, multiple sclerosis, lung disease, asthma, all different kinds of health problems. Most of the common adult health problems had a direct correlation with how many ACEs you had, adverse childhood experiences. So I thought, I think I'll do this in my patients. So what I've covered in this book was the beginning of that research, probably 3/4 of it, and what I'm just wrote up now to publish in the medical literature in our journal was the whole study, which is 218 postoperative patients of mine. And I did postoperative patients for two reasons. One, these questions are too personal to ask of somebody in my waiting room who's coming to see me about surgery. Why should they tell me the truth? Not only are they too personal, but I don't want patients to lie because they're afraid if they give an answer, I will reject them for surgery. So I didn't assay any preoperative patients. I assayed only people that knew me, that had gone through the surgery, that had recovered, that were at least 3 months after surgery. And I also wanted to be able to put the results in perspective. What were the patients like? How much stress did they put on the staff? How depressed were they? What kind of health problems did they have? How easy were they to manage? And how happy were they with what I did? And I also tested them for body shame, which is, as I read in the literature, the commonest kind of childhood abuse, the commonest kind of shame that results from childhood abuse or neglect is body shame. All those experiences create a feeling of shame in the child. Child going through these adverse experiences tries to understand them and will explain them to himself or herself to make it logical. I mean, I got beaten, but I mustn't have been a very good child. My parents got divorced, but it was my fault. They criticize me all the time, but I'm just a screw-up. So this is the way a 3 and 4 and 5 and 6-year-old child will help make sense of his or her world, and they learn to cope with it by being perfectionistic, by disappearing and being below the radar so they don't get into trouble, whatever they have to do to cope with this crazy environment. And so shame is the common final pathway, if you will, of all kinds of childhood abuse and neglect. And there are 3 kinds of shame in the mental health literature: characterological shame, the kind of person I am; behavioral shame, the way I act; and body shame, the way I look. So if body shame, if you interpret the way you feel about yourself, I'm defective and I know what it is, it's the way I look, then of course the pathway to plastic surgery is pretty obvious. And so I thought, this is fantastic. This is like the missing piece. So when I read that in the mental health literature, the body shame component of what's called the experience of shame scale, which is a recognized metric in the mental health literature. And it asks for kinds of simple questions. Are you embarrassed by the way you look? Do you like not looking at yourself in the mirror? Do you try to camouflage your appearance? Do you worry about what other people think of your appearance? Those kinds of things. Everything related to embarrassment and feeling defective because of the way you look. So I collected all this information in my patients. Now, my practice now is about 3/4 women because it's more common cosmetic surgery. And it's about 80% cosmetic surgery and 20% reconstructive, which is largely skin cancers and a few other things, hand surgery. And so it's not a broad-based plastic surgery practice. But I still separated the patients into groups, the reconstructive ones, the non-rhinoplasty cosmetic patients like the facelift and eyelid patients, the primary rhinoplasty patients who'd never had surgery before, and the revision rhinoplasty patients who had prior surgery. And what I discovered was overall in my patient population, the prevalence wasn't 64% like it was in the Kaiser medical group. It was 80%. Now, this is the first time anybody has assayed childhood abuse experiences in a surgical population of any kind, as far as I know, and never in plastic surgery. Always it's been a pediatric or general medical population. And the reconstructive patients almost exactly matched the Kaiser group because they were basically a general medical group. They'd come in with skin cancers and they'd some sort of wound closed because a dermatologist had removed a skin cancer. So their percentages of each type of abuse and neglect almost to the number matched the Kaiser numbers, but they were still fairly high, meaning emotional abuse was about 40%, and physical abuse was about 25%, and sexual abuse was about 25%. And if somebody had asked me, how often do you think these things happen in your patients, I would never have guessed numbers like that.
There's a woman named Brene Brown, and she
Yes.
did a TED Talk on shame. And
Yes, I know her work.
Yeah, whoever hasn't watched it should probably watch it. It turns out we all have shame. And it doesn't have to be all of the ACE kind of things. It can be as easy as when you're a little kid and you're asking for things and your parents say you're so ungrateful. You should, like,
right.
I mean, it's crazy what the numbers are and how much all of this has affected all of us.
That's
so,
right.
It's just a little or a lot power.
Yep. I've got 4 of these myself.
Right.
So
Okay.
it is very common, but it doesn't. These experiences don't affect everyone equally.
Right.
But in fact, we're hardwired to withstand major traumas. Your house burning down, or a bad accident, or a sudden illness, or a robbery. It's the what they call the small T instead of capital T trauma in the mental health literature. The constant drumbeat of being insulted by your parents or put down. That can go on all day long, and it's very destructive to children. And the problem is, and what many patients get defensive about, is that it can be totally unconscious on the parents' part. Mm-hmm. If someone had said to my parents that what they did was either neglectful or abusive to their children, they would have no idea what the person was talking about. They'd say, we were just trying to raise 2 good Christian children who weren't full of themselves. But they didn't recognize the effect of their behavior. So it's often with good intentions even, but it has an effect the parents don't realize. And we all parent the way we were parented. We make the same mistakes unless we recognize them and try to change them. So in conclusion, what I found in all of these patients was not only that abuse and neglect were common in plastic surgery patients, there were 4 areas where they were much more common than in general medical group: emotional abuse, emotional neglect, drug abuse in the family, or mental illness in the family. And shame, it turns out, is the big divider between patients who were happy and patients who were unhappy. When I looked at patients, for example, the revision rhinoplasty patients that had normal noses, the ones that I thought were special trouble when I wrote that first paper 6 years ago, they didn't look any different than the revision rhinoplasty patients that started off with deformities, meaning the demographics were all the same. They were just as likely to be perfectionistic or depressed, had the same amount of health problems, be just as likely to be happy or unhappy after surgery. There were really no differences between them. It's when I separated the patients, all 218 patients, into whether they were body shamed, expressed body shame, or didn't express body shame, that the numbers totally sorted out differently. The body shamed patients were twice as likely to be single, much more likely to be depressed, much more likely to call themselves perfectionistic, much more likely to have a history of recreational drug use or drug abuse, much more likely to be on antidepressants. Their childhood trauma score was much higher, and they were much more likely to be unhappy with the surgery that I did, meaning when I operated on them, they wanted another operation. They right away started picking out flaws. It wasn't good enough. It had to be done again. Something else had to be done. So I think that right now, body dysmorphic disorder, which these characteristics describe, patients who are unhappy after surgery and often not very healthy and often have frequently drug abuse problems in many BDD patients. The thing that distinguishes them is not how big the defect is. You can have a real problem, a real medical problem or surgical problem, and still be body dysmorphic. It's whether you feel shame about it or not.
And then what does social media have to do with your learnings? Because I don't know what your demographic is, but did you also look at the age of the patients that had these issues?
Yes. Well, I mean, they're not mostly teenagers, but the average age was in the 40s, but it varied. I mean, the reconstructive patients, of course, are going to be older because they're old enough to get skin cancers. But in general, the ages went from mean age of anywhere from 35 to 60. I mean, they're all basically middle-aged patients. They're not teenagers.
Do you think that's going to change, though, because of what's going on with social media and women comparing themselves to the filtered images and the Instagram models looking for attention?
I'm not sure. I think it has to, all those criticisms have to fall on fertile ground. In mental health, they call that boundaries. You know, there are verbal boundaries, there are physical boundaries, there are sexual boundaries. So if I have a good verbal boundaries, then if someone says something insulting to me or it says anything to me, it doesn't have to go in like a hot knife. I can stop that information and decide, is it true or should I ignore it? It also contains me so I don't rage and criticize and gossip to other people. So if you have a sense, if a person has a sense, even a teenager, I'm precious, I have value, my parents love me, I know I have self-worth, and it's not something that has to be earned, and it's not something that anybody can take away, and someone says something unflattering to them, or they see someone else who's different, they may say, well, you know, she's got better hair than I do, but they won't therefore proceed to say, and therefore I'm inferior. I'm not as valuable because I don't look like that person, or I don't meet I was criticized by somebody on social media. So it can be out there, but it doesn't have to go in. See what I mean?
Right. Although the younger generation, I do have a 13-year-old niece, and she's watching the influencers on social, and some of them have had way too much work done already in their early 20s, and they're being influenced by that. So I don't know. So what you're saying is you better have a good foundation to deal with, I guess, social media, because
that's right.
It's going to come at you. So you better be able to.
Yeah, I mean, not just social media, but life in general.
Correct.
And you know, a lot of people in the media, in entertainment rather. I mean, partly that's an artificial medium because they need to be flawless, and they're extremely harsh on themselves. So the fact that because their appearance is part of their livelihood, they have to pay much more attention, and they're much more likely to go ahead and have procedures done earlier than regular people would. It's like an athlete's going to work out, an Olympic athlete's going to work out much more than I would. So there are individual differences. You can't match yourself to what some young movie star is doing and say, well, it's because she did this, I better be doing it because I'm the same age. But also it has a lot to do with personal integrity. Brene Brown, her work is very good. I'm familiar with it. I think, to me, the critical difference in plastic surgery patients is a difference between being dissatisfied with something and being ashamed of it. If I'm dissatisfied with some physical feature of mine, I know I still have value. I just don't like the way this looks. A woman says, I had a good figure before I had children, and now I don't. That can be dissatisfaction, but it doesn't demean her in her own eyes as being less valuable now. So she can have a mommy makeover surgery and come out of it and be happy and go on with her life, and her self-esteem was good before and it's good after. It's the person who feels diminished, worthless by whatever behavior, appearance, anything that has a motivation that can't be fixed by surgery. So one of the things I try to say to surgeons is not every unhappy postoperative patient is body dysmorphic. The unhappiness after surgery is not what characterizes a distorted body image. It's what precedes the surgery to begin with. If it's shame versus dissatisfaction, then it's not really a surgical problem, and that's why most BDD patients are never satisfied after surgery.
But the way you do it, you're interviewing them or giving that assessment or questionnaire afterwards at post-op.
Right.
So how are you catching it how are you catching it then if you're not asking them up front?
Well, I said one of the things I say in my book is that you can't use that survey, even if patients would give you honest answers, you can't use the Adverse Childhood Experiences Survey as a preoperative screen, because people can go through childhood trauma, and because they're resilient, they still aren't affected by it, and they still become functional adults. I discovered that I couldn't predict what someone's ACE score was going to be, even though I had operated on them and knew them pretty well. Some of the most wonderful, pleasant, successful, likable, grateful patients I had would check off 8 out of 10 things on the list. And I'd say to them, how come you aren't a homeless person?
Right.
Why aren't you a drug addict? And they all had similar stories. I had an aunt. I had a grandmother. I had a coach. I had a teacher. Someone who believed in them outside the family and became a mentor and said, you can do this. And they responded to that, and they were able to escape the dysfunctional part of the inner circle they grew up in. The message for doctors is you need to really look for functional adults. You need to, in surgical terms, my criteria have always been with a patient, do I see the problem the way the patient sees it? And if this patient says, my nose is hideous, it's ugly, it's disgusting, those are bad words. One patient said to me, I look like an animal. I mean, that's really troubling. And I said to her, that's an awfully harsh way to describe yourself. Oh no, I look like an animal. She would not give it up. That's not normal language for an adult to feel. That's a repulsion of the self. That's right there is a bad sign. Patients who misinterpret or twist what I say are also not behaving like functional adults. So if I say to someone, that obviously bothers you a lot, or it seems like that bothers you a lot, and they say to me, you're saying I'm a bad person. That's not what I said. They twisted that and metabolized it into an insult, which people who are victims of abuse and neglect often do. Everything becomes something that happens to them. They have to be people who assess risks realistically, so that the people who've had multiple prior surgeries, and even when they've had complications, they go back to the same doctor or other doctors and they have more and more problems, and they still keep going ahead. These aren't people who take life. They take their own self-care rationally. They aren't careful about themselves. They're not looking after, they don't live their lives in moderation. So all those kinds of things are important. And it also has to do with just the connection that I have with patients. I call this the face of trauma because there's a page in there where I have photographs of the eyes of patients that were just non-relational. They look disconnected. They're often gazing off in the distance. They don't look at me when I take their photographs, or they close their eyes, or they look off in the distance. They have this sort of glassy-eyed appearance. They call that the 1,000-yard stare in the mental health literature. It's associated usually with chronic trauma. So, a person who makes good eye contact, who smiles, who laughs appropriately, whom the surgeon feels very comfortable and connected with, and who the surgeon, he or she can see the patient's problem in the same way, can manage it, can manage the patient, has a patient that understands that complications do occur and that all of us have them and that they have to be prepared to deal with them even if they're uncommon, and the patient who understands that perfection is not the goal of surgery. The goal of surgery is the best possible surgical result. Those are the people that are going to be the good patients. Because indirectly, you're testing for a functional adult.
What do you recommend to the surgeons who have those patients that bring in the photos of celebrities?
I don't mind that, actually. A lot of surgeons hate it, and I've actually encouraged it and I've never felt it got me into trouble. And because I can use it as an educational tool. Now, someone who's got very broad features and heavy tissues and brings in a photograph of Audrey Hepburn, if your audience still knows who that is. I have to say, the difference between her nose and yours, there's fundamental differences. Your tissues are much heavier. Her skin is very thin. So I can't make your nose look like that, but you have a bump, I can make it straight. You don't have an angular tip, I can make it more contoured so it has a better shape. You aren't symmetrical, I can give you better symmetry. You don't have a good airway, I can give you a better airway. So I try to get to the goals that I can reach that are similar to the ones the patient wants. And reasonable people will accept those. Unreasonable ones won't, and that's a good screen. So I don't mind the photographs if they're used as educational tools. I've never had a patient come back and say, look at the picture I brought you, I don't look like her. But I'm very careful. I not only say this, but after I see patients, when they book surgery, I write each patient a letter, and I describe exactly what's in my office notes. I dictate it myself. You have these 4 problems, this is what you told me, this is what we need to do, these are the problems we might have, this is the % chance that I might need to do a touch-up surgery if you want the best result I can provide. And the patient signs that, and it goes in the chart. They keep a copy, and I keep a copy. And that helps.
Okay. So how did you explain, I'm sure you must have been asked about Michael Jackson, for example. How does that happen? How does a Michael Jackson nose happen?
He's the poster boy for what I'm talking about. He had a very abusive childhood and a father who was extremely critical. And in fact, you can find a YouTube video that someone sent me of him being interviewed about the way his father said, you didn't get that nose from me. And the interviewer says to him, how did you feel when your father said that? And Jackson sort of gazes off in the distance and he said, it made me want to die.
Wow.
That's emotional abuse. So here's a young man who, despite everything, was really tormented and was constantly trying to change his appearance to meet something he had in his head. Each operation was going to make him feel, he thought, better, but it was never enough because the problem had nothing to do with the physical appearance. I've had patients like that.
Oh, what a shame. By the way, going back to that patient you had, the male who said, I had this disease and now I don't, just to loop it around, how did he conquer it? What did he do?
It was, he went back to school. He took action.
Okay.
He went back to school. He became a teacher. He became much more relational through that. He opened up, and he became married. He got married. He had children. When I see him, he still struggles. I sent him a copy of my book as a present because he turned me on to so many critical ideas, and with his permission, I put most of his letter in my book. And he said, I'm afraid to read it because it might reopen old wounds. I don't know if I. So he's still fragile. I said, no, I think it'll empower you if you read it. So I still don't know if he's read it. But so it wasn't, he hasn't transformed into someone different because he had a difficult time. But all self-harming behaviors, all shame turns us in toward ourselves. I have a chapter in my book, the last chapter, which a lot of other people who've read it say is like the dessert to the book, is all about resilience. And resilience is another one of those things in the literature that people nobody knows why it happens. You're just lucky to have it. You're resilient. And I don't believe that's true. All kinds of self-harming behaviors and addictions turn us in on ourselves. Most addictions are solitary behavior. They're not group behavior. And if you're closed in on yourself, you can't be resilient. You can't have the attributes of resilient people. You can't get support from other people because you're walled off. You can't have a sense of humor. You can't have a life perspective because you're all closed in, ruminating about how miserable you are and how much you don't like yourself because you're so ashamed.
The patients are so myopically focused internally on themselves that you can't even help them if you try because they've got
right.
walls up and they can only hear what their head is telling them versus what anyone else around them is. So, gosh, that sounds like hell.
I went to a bunch of workshops myself because of my own trauma history, and it helped clue me in to a lot of the ways people around me behaved. It helped me understand my patients, certainly myself. Good trauma work is different than a lot of traditional mental health treatment because the damage done to a young child is done to the immature brain. It's not done to the cortical, rational brain, which really doesn't hardly come online till we're about 6 and keeps getting better till we're in our 20s. So a child who is very young, even a toddler, who is spanked if he's hungry or neglected if he's got a wet diaper or ignored if he cries, learns very early on how he fits in the world, whether big people are safe, whether what happens if he's unhappy, whether anybody cares about him. And so the damage is done to the non-thinking brain, to the midbrain. That's why you go to, say, cognitive behavior therapy, which is a very common kind, isn't often very good for body dysmorphic disorder or for a lot of kinds of child-inflicted trauma, because you can explain to someone rationally that what your parents said wasn't very nice, and what your parents said obviously wasn't true because you're a good person. And the patient will say, yeah, I get that. It all makes sense while they're in the therapist's office. But they don't leave feeling any different. They still feel defective. What trauma work does is it goes back to the childhood experiences and helps you work through those and reparent yourself. So that's kind of unique therapy. And I think that may be, if I'm right about all of this, and I'm right that a lot of body dysmorphic disorder is the result of shame, and it's not just something that happens out of the blue, that all the problems in the BDD patient existed before they became teenagers and obsessed. They were all self-esteem issues and family issues and depression and so on. It all was all before. The obsession with the body is just how it manifested. If I'm right about that, then we ought to be able to treat body dysmorphia much better. Because right now, cognitive behavior therapy and antidepressants give about a 50% improvement rate for like a 6-month follow-up. That's not very impressive. And I think my hunches as an outsider into mental health, my hunches were treating at the wrong level.
Well, I've done a lot of study on this myself, and a lot of this happened, from 0 to 7 years old. So now
Right.
you've got to deal with it the rest of your life. There are some modalities. By the way, out of curiosity, have you ever heard of a plastic surgeon named Dr. Maxwell Maltz? And
Yes.
he developed a program called Cybernetics.
Yep, he was a plastic surgeon. That's right. I quote him in my book, as a matter of fact.
You two could be brothers. He had the same issue. He said, my God, I would give them plastic surgery and they're supposed to be happy, and instead they're more miserable than when they started. He's like, what the heck?
Yep. No, that Matthew Maltz was really onto something, and he really understood that you can't disconnect the problem from the patient. I quote him in the book.
Yes, I was probably 24 years old. I was working in corporate, and there were a bunch of us sitting in the office, and this girl was absolutely miserable. She always was. She was a pain in the neck, very miserable, very negative. And she got her nose done with a chin implant. She comes back. Everybody was raving to her how great she looked. And sure enough, I swear to God, the next day, I turned around and I said, she sounds exactly like she used to. She was still moaning and groaning and bitching, and she was as negative as ever. And I literally said to her, then what was the point of surgery if you're still miserable? Even then, I didn't know what I was talking about, but I couldn't believe that you fixed something and you still were exactly the same person. That's
right. Yep, that's exactly the kind of patient that made me start pulling on this thread.
Wow, good for you. So back to reality, give me some takeaways for the surgeons. Like, number one, you already went through like how they can ID them, but then what do you do when you have an unhappy patient? How do you handle that?
That's hard. If the patient will do it, I force myself to see these patients just like I would see anybody else, meaning a year afterwards. Some patients won't come back. But if they will, I listen to them and I try to give them my best advice. I won't operate on them again. And the way I handle that is when they come back, if I know I don't want to operate on this person and he or she wants another operation, when they come to the office, I get photographs right away. I always get them anyway when they come back, but I want to get them before I even talk to them, because I don't want them to walk out without me being able to document what they look like. That gives me a record of how they looked the last time I saw them. And then I listen. Often we'll put the pictures out in front of them and say, show me what you don't like. And I will try to explain, if I can, why I think revision isn't a good idea. There are patients who I think who will listen to me, and they, okay, and I get the sense that I can educate them and they'll be all right. There are other patients that I know are not happy with that, and I get a sense they're going to be angry if I say I'm not going to operate on you again. So what I tell them is, let me think about it. And then they leave, and then I do consider it again. I look at the pictures to make sure I'm not being harsh, and then I write them a letter, and I say, this is the problem, this is what I see, This is why I think having another surgery is not in your best interest, or that you do have an imperfection and I see it, but because you don't have confidence in me, I don't think I'm the surgeon to fix it, and I'd be glad to send your records and photographs to anybody you like. And I try to make sure that they have continuity, because I'm not God. I can't make everybody happy, but I don't ever say, which some surgeons say, I don't know how to fix your problem. And I don't do that with people whom I see, a first patient, the new consult, that I think shouldn't have surgery. I don't say I'm not smart enough to handle your problem, or I don't understand your problem, because that is going to right away invalidates anything I'm going to tell them. I do know how to fix it, but sometimes the cost-benefit ratio is not in their best interest, or sometimes they're too angry or too hung up on what the last surgeon did and too bitter that it's not the right time for them to go through surgery. And so I will try to counsel them that way, because I don't want them to get into trouble, and that's a lot of my job as a surgeon, is to be an educator.
Well, wait, but then what's your out? If you're not saying I'm not the right surgeon for you, because that's what I would have said. I would have said, you know what, I don't think we're a good fit. I'm not, I don't think I can make you happy. Like, what do you say other than I don't want to do surgery on you because?
In the letter, you mean? I'll say I don't think I can make you happy.
Okay, perfect. Gotcha. That makes sense.
Yeah. I mean, I just thought of something. If a patient has had a very turbulent postoperative course and is finally equilibrated, I'll also say, last time I operated on you and you were very upset for several months. And I don't know why that happened, even if I have a sense why it happened. And I don't think you ought to go through that again. I think it's too much stress for you. So my advice is to leave things as they are. You have a good result and don't have more surgery.
Okay.
Because I don't want them to keep shopping, because if they keep looking, they'll find someone who may not recognize the problem or may not be able to correct it.
For sure. Do you ever get calls from other surgeons saying, "This, I just had so-and-so in my office, and I know you have experience with her or him"?
Yes, I do. I get quite a few of those calls, and I give them the same advice I've been giving you. And I try to get them to look back, because often there are signs that the surgeon ignored for one reason or another, and I want them to be able to pick them up next time. Frequently, the commonest one is a surgeon knowing he or she shouldn't do the operation, but the patient keeps pressing and pressing and pressing. And so I always say, don't do something you don't believe in, because the patient is not the surgeon. The patient doesn't understand the biologic reality and the likelihood that they'll be better from going through another operation. And so you got to be able to feel what you did, you knew or were sure was the right thing to do. If they talk you into something and you have the problem you expected, then you own it. So I don't want them to be in that situation.
Interestingly, I've asked many surgeons who have been sued, I said, what did you learn from it? And every one of them has said, I should have listened to my staff, or they said, I had a feeling, but
That's right.
But I thought I could handle it, and I didn't want to say no. Like, they didn't want to walk away from the money, and they thought they could handle it. Yeah.
Those are very, very important points. I never ignore my staff, because patients will often be on best behavior to me and be obnoxious to the staff. And I don't operate on patients who aren't good to my staff. That's always been a rule. But the gut feelings do mean something. We have built into us a survival instinct, and there's an anatomical connection to that. It's one of the branches of the vagus nerve, and that's the survival part of the vagus nerve. The dorsal motor nucleus of the vagus is really a preservative sensation. It's mostly below the diaphragm, and if you get that gut feeling that there's something wrong, it is a biological signal that you shouldn't ignore.
I think that takes maturity to finally listen to it. I know it has for me. Anyway,
yes.
My last question is, how do you handle negative reviews when you get them, especially online? Are you responding, or how are you handling it?
No, I don't. The reason is, people who write negative reviews, they're so negative, they're irrational. And if you look at them, they're often posted at 5 a.m. or 3 a.m. And these people they're not writing something that a normal, balanced person would write. They're writing something designed to destroy the surgeon's practice. They're looking for vengeance. And so I hope that other people reading those and reading the other reviews people write about me, if they do, that they're going to understand reviews that are that bad are probably not balanced reviews. Just like, I'll always go, if I'm buying a book online, I always go to the 1-star review, even if it's got 500 5-star reviews. And it's always something ridiculous, like the book came in a dented box, so I'm giving it a 1 star. It's this kind of thing. It's like, what is the matter with you? So I don't try to do it because it's very difficult to answer those reviews without divulging information. You can't do that. You can say, if surgeon feels compelled to answer it, it's always possible to say, I'm sorry this patient feels like this. We always try to do our best. If she comes back, we'll try to make it right with her, or something benign like that. But I don't do that. They're too upsetting to read. Fortunately, there aren't too many of them. And I just have to count on the other patients that read them to recognize that the good things that people have said in my years of practice probably count for something.
For sure. So this has been fantastic. I really appreciate it. I think the audience will really appreciate it too. And how can they learn more about this topic and you?
Well, I have a website, drconstantian.com. That gives a lot of my information about the way I think about my practice if they're interested in surgical procedures, and they also will find a link to the book there. And the book itself is available from all commercial sellers online.
All right, and the book is called Childhood Abuse, Body Shame, and Addictive Plastic Surgery, The Face of Trauma. So thank you so much, Dr. Constantian, for being with us. I really appreciate it.
You're welcome. It's been a pleasure.
All right. So everybody, I hope you got a lot out of this. If you did, please subscribe to Beauty and the Biz, because I would like to spread the word to others who are also interested in building a cosmetic practice. Please give me a 5-star review if you feel so inclined. If you've got any feedback or other topics or questions, I'd love to hear from you. You can just leave me a message at my website, CatherineMaley.com. And then, of course, you can always DM me on Instagram at Catherine Maley MBA. Thanks so much, and we'll talk again.
We hope you found valuable insight on this episode of Beauty and the Biz. For more episodes, tools, and Catherine's free book, visit www.catherinemaley.com. That's www.catherinemaley.com. And be sure to subscribe to get the latest practice building strategies delivered to you. And don't forget to share this Beauty and the Biz podcast with your staff and colleagues.